Thank you. So here we go. So there's my disclosures, and this is where I come from. So we all collaborate, and these courses are educational events that allow us to learn new things. And I learnt first from Ronald, the top gentleman there, Van Heerwaarden, and I decided to set up a centre for osteotomy in the UK, and I persuaded Ronald and Christian to join myself and Rags, and we've come together in London, and we do regular lists every month where we do simple and complex osteotomy. And we've posted some videos, this is quite historical now, it's had quite a few views, and it was the original technique video that we published. We then went on to do one in the femur. This won an ESCA prize, and these are still good, but we've developed and come a long way since then. So Neil was the godfather for ESCA, and he travelled over to America with Ronald, and he said, Adrian, there is something fantastic going on in Europe in osteotomy. We need to get involved in this. So we really launched osteotomy in the UK. And osteotomy really is key. It comes first in the algorithm of treatment. And this brilliant slide from the former ESCA president, Roman Sale, really tells us where we should be keeping our patients, which is in the green, in the preservation zone before we go to reconstruction, before we go to salvage procedures. And we can use osteotomy to unload damaged areas in the knee. Arthritis, that's of course the main indication, but we can use it for laxity, for ligament issues, to improve movement and gain flexion or extension, and as an adjunct with cartilage or meniscal procedures. And again, a very nice editorial from Hirschman and Verdonk talking about this algorithm. So it really does come at the top of the table before we consider the other elements within the knee. We published this paper, and it's still, I think, a valuable paper to read. It's really the history and evolution of osteotomy, where it came from, and we divided it into three periods: historical, pre-1940, early modern years, which took us up to 2000, and then the modern latter years, which is to today. And if we look back at the different images, we can see how osteotomy has evolved from where it was to where it is now. Now, of course, it's not suitable for everyone. And although the indications have expanded enormously, not everyone is suitable for an osteotomy. This gentleman is an orthotist, and he came to me. He's only in his 40s. I'm sorry the video's flipped. And he had severe varus in grade 4. And he said, Adrian, I've been offered a joint replacement. I'm 44 years of age. So he went on to have a double level. And we know that if you have isolated disease, you're malaligned, and if we look at the MPTA and the LDFA, the critical angles around the knee, we can select patients, and we can use it to treat not just arthritis, but also manage the slope and manage instability. And what we've found is BMI is really not relevant. It doesn't matter if you have a high BMI. It makes the surgery more difficult, but actually patients do well. And that's the same in the arthroplasty world, just more challenging surgery. Age is not relevant. Professor Takeuchi from Japan has a paper looking at under 80 and over 80 years of age. And the over 80s in this large series did better than the under 80s in his study. So age is not relevant. They just need to fit the right criteria. And smoking is a relative contraindication, not a contraindication. So if we go back, we heard on our tour to the pyramids about, everything was so advanced in ancient Egypt, they could even treat fractures. And if we look back to the Greeks who came so much later, but still this is a long time ago, the time of Hippocrates, they had this Hippocratic scanum, which was a rack that allowed patients to have their limb straightened. This amazing surgeon in the 19th century, Sir William McEwen, he did 1,800 osteotomies, and he reported on these, and you can download this from the internet as a PDF. He was a dresser for Lister, so he learned about asepsis, how to actually manage the patients aseptically. And he did mainly deformity work in children, but reported on this enormous series of osteotomies in the late 19th century. And then a French surgeon in 1964, Garapi, did the first closing wedge. Mark Coventry then went on to publish and really push osteotomy from the Mayo Clinic with the step staple. But in his papers you see relatively poor results. This was all they had in those days. There was no arthroplasty, and there was a wide range of indications, a high complication rate, and often the plaster or the simple staple devices just didn't hold the patients and they lost correction. This amazing gentleman, Professor Giancarlo Pudu from Rome, then came up with this fantastic idea of making the osteotomy on the medial side of the knee and fixing it with this fantastic plate that he developed. And then, as you saw, Akram showed the pictures of these great gentlemen, Professor Staubling and Ronald, and of course Philip Lobenhofer, who then developed the first internal fixator, the Tomafix. And they went on to use this and publish and present and begin really the modern era of osteotomy as it is today. Now, we do a lot of joint replacements in the United Kingdom. We do 100,000, and I obviously also do lots of joint replacements. But we know that our patients are not always happy. In fact, there's 10% delighted, 70% are happy and would have it again and recommend it, but 20% are dissatisfied with this operation. And this is a fantastic study from Baylis, from the Lancet, which has a huge impact scientifically. And it was based on our National Joint Registry, which now has over 3 million people enrolled within the registry. And this was a paper looking at 65,000 patients with a minimum follow-up of 10 years. And what they found was a very alarming revision rate in the under 55s. Under 60, we started to see the curve go very steep. It went exponential at 55. So less than 55, 35% of the patients required revision within 7 years, with a mean time to revision of 4 years. And this is not something that we tell our patients routinely when we consent them, but it's something we need to think about. So how do we get it right? And Akram's covered a lot of this already. So a key message is in the planning. So we have to do the planning to work out where is the deformity. Do we do the osteotomy in the tibia, the femur, or in both? And we have to carry out the digital planning, and we have this very clever software that allows us, and there's a fantastic new version of this which will be made available from NuClip, which will be free. The surgeons will be able to upload their long leg x-ray, tell NuClip where they want to go. NuClip will do digital planning based on the software, and you'll be able to work out, is it the tibia, is it the femur, is it both, how much? And with these tools now, we can be really very accurate in what we're trying to achieve with our osteotomy. And of course, we do this as a routine for every case, simulated osteotomy. When Neil Thomas started work at the Royal National Orthopaedic Hospital as a trainee, he worked for a gentleman called Carl Nissen, and he used to perform osteotomy surgery, and he didn't even make a skin incision. He used to take an osteotome and strike it through the skin into the bone. He would effectively break the leg into a straight position, and then he would wrap it up in plaster. And initially, we used very big incisions, and we were very extensile in our approach, which isn't great for biology. And we've moved over the years to initially an oblique incision with the Tomafix, and then back once more to a longitudinal incision, and we do the surgery now relatively minimally invasive. Another major step forward in modern osteotomy was the biplane cut. So this is where we cut from the back to the front 70% of the bone, and then we create this ascending cut within the bone, and you can see the saw cut there coming from the medial side to lateral in the plane in the frontal plane. And this has enormous advantages. It looks complicated, it looks difficult. You're comfortable with your uniplanar osteotomy. This is a massive advance in osteotomy. In stability, you don't have to worry about the extensor mechanism, you get rapid healing. This part of the osteotomy, Alex Staubli showed, heals within 3 weeks in an HTO. We know now that we can immediately weight bear our patients fully from day one. It's painful, so most of them don't want to do that. And in fact, we encourage them to elevate, to rest, to minimize the swelling and use cryotherapy. But we've moved from first generation Poodoo to second generation Tomafix to third generation active motion plates. And I'll talk more about that in my other talks. So this is a short video showing where we are now with osteotomy. We make the incision, as you can see here, and we come in, and you can see we're finding the front of the tubercle. This is Christian Clay operating, and this is a relatively new video. You can see something that I'm going to talk about later, and it's a bit repetitive, but it's so important. This is the new retractor that we've developed, and I'm going to talk about the technique for placing that on the bone, so you're completely safe, and you can ensure that your cut is going to be safe. Here you can see the retractor in position. You can see the MCL above. In fact, I'm going to go more into this in the other talks. I'm going to advance and not dwell on that at the moment. And in fact, we had an amazing review of the literature just now from Akram. So we know that the long-term survivorship of osteotomy, even in this historical study, very good 10-year survivorship. This is a historical paper as well from Philip, but was a great piece of work done in 3 centers. And you've seen our paper, great 10-year data, 89% in 100 patients, showing good survivorship. And anecdotally, if I just go back, Ronald did a clinic with René Martin, who was his mentor, who taught Ronald van Heerwaarden about osteotomy. And Ronald had the pleasure of doing a 20-year follow-up clinic with René. Patients coming in 20 years down the line happy after their osteotomy. This really does stand the test of time and often is the last operation that a patient will have. A significant problem with osteotomy is swelling and pain. And now there are these cryotherapy devices. We used Game Ready previously, now we use this Physiolab device, which is pressure and ice and allows the patient to self-apply this. We do it, actually, we put it on as part of the dressing, and the patients use it regularly for the first few weeks, and it significantly reduces their pain and swelling. So ESCA is a great organization, much like EGA, and we need these organizations to actually bring us together and to have some sort of consensus on what we should be doing. And the ESCA came together, and each year now, ESCA tries to do a consensus. And in fact, we got together as the osteotomy committee of ESCA, and we did a consensus project for 2 years leading up to the recent Paris ESCA. And this was led by Mathieu Olivier and Matt Dawson and Ragbir Kakar. And it went through its different drafts and iterations, and it came out with some recommendations. And in fact, it was a fantastic piece of work, and it won a prize from ESCA for being the most beneficial consensus project. I was lucky enough to be on the arthroscopic revision ACL consensus as well. This one won a prize, and it was a huge amount of work, but particularly by Matt and by Matthew Dawson. So it said age and gender really not relevant. So this idea that men or women, one may benefit more, is not the case. It's not better in men or better in or worse in females. In fact, females do very well with osteotomy. And in fact, as I said before, you can do this in patients over the age of 80 if they're appropriate. BMI is not a contraindication. The ISACOS guidelines from 2004 are now outdated. Of course, smoking is something that we need to be aware of, but it's not a contraindication. You just perhaps need to counsel the patient. It may take longer to heal. There is a risk of non-union, etc. Early lateral compartment osteoarthritis is not a contraindication, grade 1, grade 2. And in fact, in certain units, they even go further and say if the patient is very symptomatic and young with medial OA, it doesn't matter what's going on in the lateral compartment to a degree. These angles are critical. So you need to look on your long leg x-ray and determine what is going on at the knee in terms of the mechanical medial proximal tibial angle, the lateral distal femoral angle, and the joint line convergence angles. Where should we correct to? And this is a brilliant paper from Andreas Imhoff, and we do have this individualized approach. In our unit now, we only just overcorrect, 50 to 55%. That's what we aim for. And in a very varus knee, if they're slightly undercorrected, we don't see that as a failure. We want to avoid joint line obliquity. And when we're aiming for our hinge, we want this to be in the proximal third of the fibular head or just above it. And this is obviously something you can all download, this consensus project, and you could find out about these recommendations, which really bring you into the modern era. So early full weight bearing is recommended. I've done the osteotomy on the Tuesday. My patient can fully weight bear on the Wednesday in a high tibal osteotomy, one which has gone well. Where are we with equipment? This is all you need to do an osteotomy, these simple tools. You don't need lots of equipment, and you can do it if you want, and you're advanced. We can get to a point where we can do it very minimally invasively. In fact, we've increased our incision slightly recently to 5 centimeters because we used a bigger plate more frequently. And we have good 10-year data. We have active patients that remain active, and you saw that lovely paper from Andreas Imhoff talking about return to sport. So what about the future? Well, obviously these are coming, and the robots will be delivering osteotomy surgery at some point in the next decade incredibly accurately. And this will be a massive step forward and will allow us to incorporate osteotomy more and more into our surgical algorithm. But one thing that we really can always say is you currently can't beat that human touch. And in fact, human dexterity, decision making, and the ability to actually do things at a simple base or more advanced level at the moment can't be beaten. So osteotomy is the knee surgeon's choice. Again, I'm sorry that the video has rotated. My good friend Anat Joshi, who brought arthroscopy into India, he had his osteotomy performed as a live procedure. Mark Ferguson there in the middle, he was and still remains an amazing orthopedic surgeon. We did his osteotomy on the right, and Zayed, who you've seen actually speaking so eloquently at this meeting, this is him day one after his osteotomy, and then he sent me a ridiculous email of video of him wakeboarding, and we saw actually his final slide, his final picture, when he was speaking 2 days ago, showed him doing a flip wakeboarding, so his knee is perfect. So it's the surgeon's choice. So we can achieve reliable, good and long-term results with modern osteotomy with the right experience, having the appropriate team, careful planning, team approach, rapid surgery, minimally invasive surgery. And there is a bit of secret sauce, so the teaching and the education is very important. If any of you are in the States, we're running the first US course in November in Washington. Please come, and please come and visit us. Thank you very much.